with us to talk about, as you can see, sickle cell disease and vaso-occlusive episode management. So take it away, sir.
I appreciate that. Thank you very much. So hello to everybody out there. And my name is Thomas Gregory. I am an emergency medicine and pain and palliative care pharmacy specialist here at Cox in Springfield, Missouri. I've been doing this for, at least here in Springfield, for around 5 years. Prior to this, I've dealt with the number of sickle cell patients back in my previous practice in Kansas City for around 10 years. So what I'm hoping that we're going to get out of today is some good discussion points. I want everyone to feel comfortable just asking questions in the chat at any point in time as those come up. Sometimes I do speak a little bit fast, and I do apologize for that, but sometimes I want to get to more pertinent material. I don't really have anything to disclose at this point. So hopefully everybody was able to get the article and, more importantly, the guideline from ASH here back in 2020, looking at sickle cell and how its recommendations are a little bit different from some of the previous versions of those same guidelines from a couple different sources. So first up, I want to just touch on just basics of pathophys and overall how the disease progresses, how it's going to look for you. And I can give you really two different perspectives. The first one's going to be as someone that sees these patients in a clinic, but I'm also going to be able to give you a perspective as to a pharmacist that works in an emergency department where these patients will come in an acute crisis and are going to need some type of management strategy. It's really important for every pharmacist to recognize that while it's important for us to be as safe and effective in our medication therapy, but we also need to be compassionate. And not all of these patients are going to receive that type of compassion. And sometimes even I've had my fair share of compassion fatigue, especially when you see the same people over and over again, when sometimes you would like to do something different, but you realize that the most important thing is trying to get them stable, and you know that you're doing the right thing for the patient. So overall, you're looking at a disease that affects basically 100,000 Americans overall. You've got your demographics there. And again, a lot of your population is going to be African American. Now, that doesn't mean that there aren't Asian American, Middle Eastern American, anybody else that doesn't have this disease, but it's really concentrated in this African American type of population. And if I'm using inappropriate terminology for demographics, I apologize, but this is directly from the CDC's data. Keep in mind that sickle cell trait is something else that generally gets lumped in with sickle cell disease, and it is not the same thing. We're going to go into that here in a little while, but keep in mind that you will see a whole bunch more people with sickle cell trait. And if you just kind of reach it back in the Wayback Machine to that little bit of genetics that you went through in pharmacy school, you'll remember that that makes a lot of sense that someone would have trait as opposed to actual sickle cell disease. Why do we care, though? So, and one of the biggest things that I think of is morbidity, mortality, because those are the things that are really going to impact the patient's life overall, their family, but also on the healthcare system where you're operating from. Something that I think is interesting is just from the use of vaccinations, we were able to decrease mortality over a period of 3 years by almost half. I could almost even, turn around and say the same thing about a COVID vaccine, but I'm going to digress and not cause World War III with a group of pharmacists from around the country, even though I think that vaccines are good. But right now, we're looking at a current mortality, at least in the first 3 years of life, of around 1%. And overall, that is great compared to what we used to have. Just a little bit more on demographics. This is a really expensive disease. Just looking at hospitalizations and the fact that a lot of the children that account for this, because these kids are born, they're going to experience much more likely to have strokes and other vaso-occlusive disorders. Even with all of those patients that are seen, generally around 40% of both of those groups, whether it be from adults or from kids, had at least one hospital stay in the previous year. Here's a little bit of a graphic representation of what I was showing you. So in the 70s, if you had sickle cell disease, the likelihood that you were going to survive that, you were looking at a crapshoot, if you were even going to get that. But with vaccines and with things like bone marrow transplant, bone marrow transplants, which is really the only way to truly cure sickle cell, and some of the other medications that we have that do affect morbidity and mortality, we've been able to extend life expectancy, at least back to 2005 data, up to around 40. So we doubled it. Now, granted, it took us almost 40 years to get there, but progress is still progress. So everyone's aware that you have standard hemoglobin, large A, which is standard A hemoglobin. A2 hemoglobin is going to be more of that two alpha chains and two delta chains, because remember that that hemoglobin is comprised of two alpha chains and two beta chains. So this is specifically looking at those alpha chains in red right there. The pathologic hemoglobin that we're really going to focus on is this bottom one, this S disease. So your beta hemoglobin actually is in a bad in a not ideal configuration, or bad configuration, whichever you want to say. This is what's considered to be traditional sickle cell disease. Now, whenever you have, so in order to determine that, you're going to have some data. You're going to have some kind of some type of diagnostic tool. Well, what's the diagnostic tool that we use? Well, that's a gel electrophoresis. That's still the gold standard and has been the gold standard for a long time. That really tells you whether someone has HBS, which is real sickle cell disease, or if they maybe have A2, or if they have just standard wild type AA hemoglobin, or this also looks at F and a couple other things in C. But really, it's that HBS disease that we really are focusing on here, because that's going to be where the largest impact in terms of morbidity and mortality come from. These are also those patients that have this hemoglobin S. They're the same ones that when they come in and they have their blood drawn, you're going to see a hemoglobin between 6 and 8, and nobody's going to freak out, because even though that, yes, they're below 9, they're below 10, they live there. That's their entire life has generally been in that hemoglobin 6 to 8 type of range. And actually, there's data out there that indicate that if you transfuse them past that, you might actually cause some negative sequelae later on. Now, patients are going to have sickle cell disease don't always have a crisis every single day. But what you do see when you are in a crisis mode, you're going to see a couple key labs that will come back, and we're going to talk about that in a little bit. One of the things to really remember with hemoglobin, with regards to sickling hemoglobin, is that this generally has an impact in specific areas. And we're going to talk about why Howell-Jolly bodies and target cells are important when we get into where those blood cells actually kind of get clogged up, if you'd like to think of it that way. So I kind of talked a little bit about SC pathology as well. This is actually the second most common form of sickle cell disease. You do see some splenomegaly and a little bit of anemia, but your hemoglobins are still going to run in that between 8 and 10 range. So still slightly standard for wild types of basically everyone that doesn't have SC or S pathology. Now, I mentioned trait and the fact that you have a lot more patients that are going to have trait, because remember that sickle cell is going to be HBSS. It's 2 S's if you're just born with one from mom, one from dad, versus just one from a parent and the other is wild type, whether it be A2, doesn't really matter. You're still just sickle cell trait. We don't have any objective data to show that these patients really have the anemia. Doesn't mean that they don't have pain, but the likelihood that it's objectively from sickle disease is unlikely, because keep in mind that because sickle cell is a recessive gene, you actually have to have both in order to have the sickling cells. So while sickle cell trait is a possibility, you're not going to have a hematologist or a hospitalist or whoever you're working with get really kind of worked up over, oh, we need to do all of the things because they have sickle cell just because they have trait. They may have pain, but that pain does not have to be from, and is unlikely to be from, sickle cell alone, because they don't have sickle cell. Doesn't mean that they can't pass it on to their kids, but it does mean that it has to be part of our thought process. Why do we care about sickle cell so much here? Well, from an acute care standpoint, you're going to care about it because of a thing called acute chest syndrome. Acute chest syndrome is where you actually see a drop in your oxygen consumption. There's a likelihood that you're going to have an infiltrate on your x-ray, And that's a way to get up into the ICU very quickly, because anytime you're going to affect heart, lung, neurological, those are the things that generally are going to end up in the unit, right? So in this instance, you would have pulmonary and cardiovascular as a potential problem with acute chest syndrome. So these are patients, if they really have acute chest syndrome, they need to go to the ICU. They need to stay there for at least 24 hours. You need to treat their pneumonia if you see it on a chest x-ray. So even though you are the pain and palliative care pharmacist, doesn't mean that you're still not responsible for making sure that we get the proper care to your patient. So asking those kinds of questions and being aware of it, I think, is important. I already talked about this, but when you have sickle cells, essentially, if you just look right over here, you've got this blockage on this picture. That's because those sickle cells stick together a lot easier. I kind of think of it as if you had fibrin that was running around that was actively recruiting more fibrin, which is exactly what happens in a clot. That's what's essentially going on, but it's with the red blood cells as opposed to fibrin and platelets and everything else that you typically think of with clots. So these would be clots that are rich with red blood cells, not platelets and fibrin and everything else. But they still cause blockages. They still cause problems distal to where the blockage occurs. And so think about where those small vessels are located. So things like the pulmonary vasculature, things like the spleen, things like the liver, all those places are going to have that potential for increased risk of clots. And the way that I generally reflect that back to a patient or a patient's family member, especially if it's a first time diagnosis, I talk about it like it's a body wide heart attack. So essentially, you've got a blockage, and that's causing that pain because you're causing ischemia downwind of there. So if it's in the lower or the upper extremities, that's why they're in such pain. It's because there is essentially you're having ischemic damage. So, and I have that acute and chronic pain at the bottom there, which is really what we're going to focus on with vaso-occlusive crises. And really, this is the most common way that sickling and a patient in a sickle crisis is going to present to you, whether it's at the hospital, in a day facility, at a clinic. They're going to have pain from this vaso-occlusive crisis. As I kind of have in there, these are the different places that it generally targets, causes the hypoxemia. The biggest thing here is that probably dehydration and temperature changes. If you have any patients that live in the north, for example, if they're in like New England or if they're in North Dakota, Washington State, especially when winter hits, they actually increase the likelihood of having these vaso-occlusive crises, because if you think about it, they're not going to really respond well to general temperature changes. If you have if you're cold, what does your skin do if you put an ice cube on it? Well, it blanches because you're actually constricting the blood vessels and you're decreasing that blood flow to that area because you're trying to conserve that temperature, that heat in your core. So if you've already got the likelihood of causing ischemia, plus now you're going to have temperature changes like cold or dehydration, then yeah, you're going to have an increased risk of having more of these ischemic based uh, sequelae or complications. The one thing that's nice about VOCs is generally the same patient's going to have the same number of crises year after year after year. So they're generally going to be pretty consistent on that. So that patient that comes in once or twice a year, they're probably just going to come in once or twice a year unless they have a real change in their overall pathology or something else medically comes up. What happens during a crisis? This is more of the words version, and then I kind of already skipped ahead to what it looks like graphically. But generally, the patient's going to realize that they're getting ready to start a crisis because they're going to be a lot more tired than normal from baseline. They're going to start experiencing some distal paresthesias, some weakness, maybe a little bit of yellowing of the eyes. And that's that prodromal phase, that right before they actually get into a vaso-occlusive crisis. But then they start getting into that infarctive phase, and their pain level, oof, that goes from like a 2 or 3 at baseline, we're going up to an 8. So instead of just, it's kind of annoying, it's the shark jumped out of the water, it grabbed onto both my legs, and it's trying to rip it off. That's pretty much as bad as it gets. And that's where they feel like they are. And they'll stay there until they get their pain under control. You get them rehydrated and you get them back to relative normal baseline laboratory values. So you do have a lot of subjective, it's pain, it's a lot of subjective, but you do also have some objective data to go off of to show when you're about ready to get out of the crisis, which is really good. And that's when we get into that resolving phase. So you start to see that a couple days after you've been in that post-infarctive phase, everything kind of gets back to baseline. The patient feels better. They go, hey, look, I'm ready to, get back to doing what I do and be not here. And that's a great place for me to be because I can go take care of my baseline pain at home. But it's when they come in that acute crisis mode and then that VOC mode that we have to be very observant of. Do they have acute chest? And whatever their pain is, we're always going to believe them, right? Because that's our job. We believe what the patient subjectively tells us their pain is. That's how things are supposed to work. We don't know what their pain is, but we have to treat it as much as and as best we can, as safely as we can. So here's that picture, and I always like the faces on the side. So in that prodromal phase, you really see you've got that, they stay at that baseline, but that initial phase, they really start ramping up and they stay there and they're above their baseline pain for maybe a couple days. Some people it's a little bit less, some people it's more, but in terms of that consistency, that's the other thing. If they come in and they generally have a couple of crises a year and they last for about 3 days, they're just generally going to come in about twice a year and it's going to last for about 3 days. The time in the established phase generally is consistent. Now, like I said prior, if you have changes in pathology, there might be some differences, but generally it stays consistent. Well, why do we care as pharmacists? Well, because the likelihood that acute pain turns into chronic pain is pretty high. It's about 30% in adults. And even kids, they report having some kind of daily pain over a period of time. And it could be neuropathic, it could be nociceptive, because keep in mind, while it's that infarctive pain, but they also have the paresthesias. So the infarctive part really looks more nociceptive, while that neuropathic component, you still have nerve involvement here. So it could be either. Now, you can do a number of other tests to figure out just from you could do functional MRI and you could look at your temperature sensitivities and such from a diagnostic standpoint. But for you as the pharmacist, while those data are useful for a provider or for the physician or the other clinician, this may not be super useful in helping you get to your next step in your treatment plan. Well, I already talked about the fact that this is a group of pharmacists, but why are you showing me a big old list of nursing implications? Because our job as pharmacists is to make sure that we can talk to our nurses, our patients, any provider that asks us about what this disease state is and how we can help that patient get through it. So these are the things that your nursing colleagues are going to be focusing on. Things like avascular necrosis, priapism, acute chest syndrome, splenic sequestration, infection, organ failure, all of those things still come into play. And I want you to just be aware of them. And it's not something you need to spend a ton of time on, but being able to speak to another provider about what's going on from their aspect, it helps you integrate into your team. It helps your patient know that you're working with a team so that they know that it's not just like these different people way out in left field that are all trying to work independently of each other. It's all trying to do the same thing. Well, since about 2017, we actually had a couple of additions to the standard armamentarium when it comes to sickle cell. So I'm just going to really briefly go through a lot of these things, but keep in mind that prior to this, the only things we really had were fluid hydration, hydroxyurea, which I have that one on here because that's more of an indicated for pediatrics, which we'll talk about, and then bone marrow transplant. Because keep in mind that bone marrow transplant, by removing the old marrow and transplanting new bone marrow that doesn't have that the genetic material that causes sickling, that's the only way really to fix this. So these are the four new ones that we're going to talk about, and I'll try to do it relatively briefly. So L-glutamine is a non-essential amino acid that really just helps to work on preventing oxidative stress. So you go back in the Wayback Machine again into pathology, oxidative damage happens, and that's where that nociceptive pain comes from, is because that oxidative damage is what causes the it helps work on those sickling cells themselves. And again, and this is an oral medication. This is something that can be given to your patient. It's dosed based on weight, can be given with or without food. All right, well, that's nice, but tell me, what's this really going to do for me in terms of morbidity, mortality? Well, the first thing I got to throw out there is that this is a particular FDA approved L-glutamine, which means that, of course, it's not bioequivalent to anything else. So if anyone says, well, I'm just going to go to the health food store and go pick this up, technically, it's not the same standard, because keep in mind, supplements don't always have to have the same standards when it comes to potency and content and the different binders that are all associated with them. This is an FDA approved medication to manage these types of crises. But at the end of the day, they were able to decrease the amount of vaso-occlusive crises over some period of time for these patients with sickle cell disease. Now, I didn't say anything about mortality, but I did say that we were at least able to reduce the number of vaso-occlusive crises. Anytime that you can reduce that, you decrease their incidence of going either to a day hospital or to your emergency department, because they're just not experiencing those kinds of negative sequelae. So this hydroxyurea is actually indicated for patients all the way to 2 years and older. Hydroxyurea, the actual hydria, was not indicated for kids prior to this. Now it is. But keep in mind that the dosing is going to be a little bit different. So I have on there that your initial dosing for kids will be 20 per kilo based on weight. And in adults, generally, it's based on 15 per kilo. And all you're going to do is you're going to increase your dose until you cause myelosuppression. Because keep in mind, hydroxyurea actually was used as an oncology agent prior to us discovering that it increases fetal hemoglobin, which actually helps to prevent vaso-occlusive crises because it decreases the amount of sickle hemoglobin that's in the circulation. So essentially, you're going to be dosing a medication until you get to myelosuppression, which that sounds kind of dangerous, at least to me, on first blush. However, if you've got someone that's stable and they're not in a crisis and you're able to manage and get them to that point where you can get a good amount of hydroxyurea in them without having the bone marrow suppression, if that keeps them out of the hospital, then that's a great place to be. Now, what about morbidity, mortality? You give this to kids at least, you decrease vaso-occlusive crises, you decrease their hospitalizations, you decrease their likelihood of acute chest syndrome and the number of blood transfusions they need. This also decreases mortality. So in the grand scheme of life, I think that the risks are outweighed by the benefits of hydroxyurea, and that's really been proven over the past 40 plus years. Voxelotor is another new medication on the market. This one actually is used to it's a polymerization inhibitor and basically increases the ability of sickled hemoglobin to bind to oxygen. Because keep in mind, the problem is with sickle hemoglobin, it doesn't bind to oxygen as well. This just increases the likelihood of that. Standard dosings around 50 is going to just be 1,500 daily. You've got your recommendations for concomitant meds right there, especially I think in terms of like strong cytochrome P453A inhibitors, fluconazoles. Now, if it's just like a one-time dose of fluconazole, I'm probably not going to worry. But if you've got a patient that's going to be on long-term fluconazole, long-term voriconazole, if they're on HIV medications, that's something that you would need to keep in mind. Well, let's talk brass tacks again. So morbidity and mortality. So at least for patients that received this versus placebo, you really didn't have a big difference in vaso-occlusive crises or in ADRs. So in the grand scheme of life, what did it do? At least objectively, it increased their hemoglobin response compared to baseline. So this is more of a plus minus. I'm not really getting the morbidity mortality data that I'd like, but it is something else that could at least on paper make things better. The newest one here, I think, is the most interesting, and that's crizanlizumab. And don't ask me to say that again because I'll probably screw it up again. This is a humanized IgG2 monoclonal antibody, and it binds to a specific P-selectin on sickle hemoglobin. What that does is it prevents it from binding to the activated endothelium and activating platelets. So essentially, I'm giving a monoclonal antibody to decrease the likelihood that I would cause a vaso-occlusive crisis, at least in theory. That's the mechanism behind it. This is for patients that are at least 16 and older, and this is still a monoclonal antibody, so you do have to do the initial dosing, and then a couple of weeks later, you have to ramp up to this. Brass tacks again. Let's talk about this. For those folks with sickle S, sickle C, or even with beta thalassemias, they took a lot of these patients between 2 and 10 vaso-occlusive crises per year, and that's who they studied in this particular. I think this wasn't the Hope. This was just their study. Sorry. So they looked at 5, 2.5, and placebo milligrams per kilogram dosings. And then they looked at just how many vaso-occlusive crises they had over the next 12 months. The only one that really showed a statistical difference was the high dose group. And there was about a 50% decrease almost. It was statistically significant compared to your placebo, which was, again, at baseline. Really no difference in hospitalizations, and their time to it did decrease the time to their first vaso-occlusive crises after starting treatment, which was useful. So you did see really you saw a decrease in the number of vaso-occlusive crises. So from a morbidity standpoint, that sounds pretty good to me. Again, this is a monoclonal antibody, so you did see an increased risk of pyrexia and influenza in those treatment groups. You can even see your lines here that show just where you were in terms of overall likelihood of having more vaso-occlusive crises. What about some other treatments in the future? So I've just got a couple of them listed here. None of these are FDA approved, but these are things that I think it could be interesting to look at sometime in the future. All right, so I've gone through a lot of pathology. I went through some of the newer drugs. Let's get to guidelines. Well, why is it important to know what these different guidelines are? Because why is this guy going to tell us about stuff from 2014? This is old hat. This is like 7 years ago. I was still in pharmacy school then. Well, I was still actually practicing back then, actually. But most important thing is that we need to recognize that data are still appropriate, and each of those guidelines are going to have something I think that are useful for you to walk forward with, because you can see kind of the transition from the one guideline to the next to the next. First one's NHLBI, and this was back in 2014. And I'm not going to go through the whole thing, but I am going to focus on those things that I think are the most important for you at the bedside. For adults and for kids with sickle cell and that they're having vaso-occlusive crises, we need to get them rapid treatment with parenteral opioids. I think that's probably the most important thing that I can walk away from this guideline with. Yes, they want to use NSAIDs, but there's some issues with quality of evidence. But if you get a patient and they're hurting and you know that they have sickle cell disease, the likelihood is that you're going to try to draw labs, give them fluids. You need to hit them with parenteral opioids, because that's going to be the thing that gets them out of that initial phase, or at least start decreasing the likelihood that they stay in that post-infarctive phase for a long period of time. That the fluids really help the most, but getting pain control, because if you get behind the 8 ball on these patients and they're used to having really high doses of opioids when they go home, you are going to be holding on to this patient for a lot longer than you thought. And that increases their risk for atelectasis, increases their risk of DVTs, increases all their standard morbidity risks for being in the hospital for a long period of time. So the sooner you can get opioids in them, the better. And then also, as I kind of mentioned with atelectasis, as soon as you can start incentive spirometry with them, decrease their likelihood of having acute chest, decrease their likelihood of having atelectasis at baseline, much more likely you're going to have positive outcomes, be able to get them out of the hospital sooner. What about when it comes to chronic pain? You know what they say? We encourage them to use different things, and it's a weak recommendation with low qualities of evidence. And they came back later and even said that we really just don't have that high quality evidence right now. We need some. So that's what happened in 2014. Well, AAFP actually came out with some recommendations as well. And I'll kind of summarize theirs a little bit quickly for you. If the patient comes in and they are experiencing a vaso-occlusive crises, is this patient at risk for acute chest or some other kind of negative sequelae where they would be unsafe to be at home? Then they need to go to the ER. They just need to go to the ED, be evaluated, be managed, everything like that. But if they're fairly controlled and it's just their pain management that's the problem, do they have any kind of a day hospital? Do you have any kind of in outpatient management treatment available for them? You could manage them there in an outpatient type of environment and be able to send them home. If you can get over the hump of that acute pain right there, much better to have them just go to the day hospital for a few hours as opposed to go to the ER, have all of the tests, likely be admitted, stay in the unit, or maybe go onto the floor depending on how sick they are, and increases your morbidity again. And that's basically what their algorithm shows. And goes into a little bit more based on, again, using parenteral opioids for adults and kids. And this is really just more of a rehash of the NHLBI guidelines. That's why I didn't actually go into it a lot, but you can look at those data there as well. Well, we're talking about opioids, so we're going to have to talk about the CDC guidelines. So everyone remembers, or at least a lot of you remember. I know Lynn remembers, I remember because we lived through this. In 2016, they came out and basically everyone said through these guidelines that 90 milligrams of morphine equivalent means that you're either if you go over that number, you're a horrible person, you should be drug out in the street and shot, and you probably should never ever practice pharmacy again. And you did all these bad things. And then they had to come back because a lot of states glommed onto that. A lot of insurance companies glommed onto that and said, oh, well, you're over 90, so we're not going to pay for it. Oh, you had all these experienced like issues. Oh, well, that's because your opioid was too high. Well, the rest of us sat back and went, oh, this is going to kill my soul. Don't do this to me. So wisely, they came back out and they published some recommendations because of that misapplication of that hard number of 90 milligram morphine equivalents. And they really looked at patients that were in active treatment of cancer, patients with sickle cell disease, and in those patients with post-surgical pain, because all three of those are very different disease states compared to, quote, a standard chronic pain patient. Because each of them, you have a lot of other things, a lot of objective data that are going on. And also just subjectively, if you're post-op, you're going to have more pain acutely. So what did CDC really come out with? They said that you really need to be looking at that number of 90 in those patient populations. It doesn't mean you stop it, because the last thing you want to do is stop someone's opioids acutely. You throw them into a pain crisis. Then they go back to the ER, and then they may actually get acute chest syndrome where they could have real morbidity and mortality. Or the fact that you're allowing a person to be in pain, which is inappropriate and unethical in my estimations. And CDC just wanted everybody to take a step back, stop saying that 90 milligram morphine equivalents a day is a hard stop, and try to make their lives better by saying that you need to look at this on a step by step, on a case by case basis, and look at the patient. Taking the time to not just go through the electronic chart and say, okay, well, this is what's going on, and this is the number, magically it's going to be fine. You actually have to talk to the patient, figure out what's going on with them. What are they able to do? What are their activities of daily living? All of the things that everyone here already has an idea about. Well, last year, the American Society of Hematology came out with some guidelines as well. And since everyone read them, I don't want to go through line by line. I'm going to go with the ones I think are the most appropriate and the most important. So this one, the first one even comes out and says, if you've got an adult or a kid that comes in with acute pain from sickle cell, you give them opioids, and you give them what they called optimal pain control within an hour. And I think that that's a reasonable assessment, but if any of you have worked in an acute care environment, I am very aware of this because in my emergency department, I have some people that wait 8 to 12 hours because I have people that are much more acute than them. And I have issues with boarding, and I have a lot of things that prevent me from being able to see a lot more of my patients than I normally would in the ED. So the other thing to keep in mind is that's one of those, the underlined ones here are strong levels of evidence. So in 2014, we knew we needed to hit them hard and hit them quickly with parenteral opioids. And in 2020, we're basically reaffirming that. So I think that that's pretty much a consistency. Now, granted, 30 to 60 minutes, you need the frequent assessments because of the fact you're going to give someone parenteral opioids. And in a number of these cases, you're going to be hitting them with 10 of morphine, 2 to 4 of Dilaudid. Any of those, sorry, I'm using brand names. Poor form on me. Hydromorphone, oxymorphone, whichever one you're going to use in terms of your parenteral opioid, just make sure you've got appropriate respiratory constraints and that you're doing your assessments. I'm not saying to use Narcan on them. And that can be, I'm sure that at least one person will go into a discussion over Narcan. That doesn't need to be me. It's very infrequent that I recommend using naloxone for patients that come in that are acutely um, not breathing well, unless they truly have apnea and it's from a real organic cause. Anyway, they want you to use nonsteroidals, which would make sense. This is a nociceptive pain. Nonsteroidals generally you're pretty good with that. The one thing I will throw out there on nonsteroidals is that keep in mind these patients get real dehydrated. So if you've got a dehydrated patient, is it really great to give them a medication that's going to potentially strangle their kidneys? I'm going to be cautious on that. You could, but you have to be careful. Know what you're using, be aware of it. And that's one of the reasons I'm okay with using a dose of ketorolac, maybe 15 of ketorolac IV times 1, but I don't like to hit them multiple times, but I love using lots of fluids. Make sure you're using fluids because really it's that rehydration allows for more blood volume. That's going to be the likelihood to decrease that sickling by the clumping. So fluids is probably one of the biggest things other than making sure they don't have acute infection in their chest. And you don't have to use just opioids, but opioids generally in the first couple hours are going to be the strongest thing to help you out. You can do the 10s, you can do other non-pharmacologic means. If they're going to be hospitalized, go ahead and admit them to a standard, either an ICU bed if they are having an acute chest syndrome or there's likelihood of acute chest syndrome, they need to go to the ICU. They need to have the frequent monitoring. You are worried about the fact that they could have an infection, which leads to pneumonia, which is why you have to get the chest x-ray and all the rest of the labs. But if it's a patient that is fairly controlled and they don't have underlying pathology such as pulmonary or cardiovascular in nature and it's just from pain, if you can get them into a day hospital, well, that's going to be best. Well, that also is a reflection of NHLBI and a reflection of the AAFP in terms of if they're not super sick, have them go to a day hospital. So one other thing, and this one was kind of interesting to me, the second one down, for adults with sickle cell and no other identifiable cause beyond sickle cell, they actually suggest using SNRIs like duloxetine or milnacipran. So milnacipran really wouldn't be FDA approved for this because that's going to be really only for fibromyalgia pain. But duloxetine does have a couple of neuropathic pain indications officially. So it's something that you could use, but keep in mind now you're dealing with an SNRI, which that can always lead to potential for serotonin syndrome, even though I can count on one hand how many times I've seen serotonin syndrome, whether it's be in the clinic or in the ER. But it is a possibility, and it's something that a lot of pharmacists like to glom onto. And I do want to make sure that you are vindicated in the fact that you should be aware of them for SNRIs, SSRIs. Also, don't use SSRIs for pain management. There's a big there was a Cochrane review in 2002 that basically said if you're using SSRIs for pain management, it's going to give you a lot of nothing and only an increased risk of drug interactions. But that's beside the point. Let's see. They would sometimes they even use tricyclics. So for that patient that maybe is inappropriate for using SNRIs, you could try tricyclics. However, then you have all the instances of ADRs associated with tricyclics, like orthostatic hypotension. Also, I like using nortriptyline over amitriptyline. Ask Dr. McPherson about that later on. I'm certain that she would be more than happy to give you lots of information on secondary versus tertiary tricyclic antidepressants at some point in the future. I won't steal that thunder from her. That's not nice because she'd probably thump me later. I know she would. Anyway, so if you don't, the other thing to consider would be a gabapentinoid. So part of this is neuropathic in nature, as I mentioned. So we talked about nonsteroidals. You could also use a gabapentinoid here. Now, I would be cautious in the fact that you're going to give them hydration fluid. So if you're going to start someone on gabapentinoids, if you're really going to treat neuropathic pain, keep in mind you need around 1,800 milligrams a day. But if you're not going to start them on like the anacarbal formulation, you really can't ramp up to that dose real quickly. Just be aware of which gabapentinoid you want to use, whether it's gabapentin, pregabalin. I have no preference, but make sure the patient can afford it and make sure the patient's going to be tolerant of it. So it's again, start low, go slow. Let's see, more. The bottom one here is probably another good one to have. So for adults and kids with sickle cell and emerging and or recently developing chronic pain, they do recommend the use of continuous or chronic opioid therapy unless it's refractory to other modalities. So if you're using, so just like in other types of pain management, if you've used all of your multimodal analgesia and it's not getting you the trick that you want, sometimes you just got to go to opioids. And sometimes those opioids are going to be the thing that prevents them from going into a VOC. And if that keeps them out of the hospital, then I'm pretty happy with that. And again, this just goes into more on using chronic opioid therapy and the fact that opioids should not be your first line or your end all be all, and that using multimodal is an appropriate stance because it's nociceptive, it's neuropathic, it's both, and you're going to try to tailor it based on your patient's symptomatology. All right, so I talked about 3 different guidelines. What's the most important things for you to keep in mind? Here are the things that are at least based on evidence. They need rapid access to treatment. If they have complex comorbidities, you got to go to the ER. If they're not complex and it's just pain management, if you've got a day hospital within your system or you can refer them to an outpatient sickle cell clinic for management, that's great because that's not going into the ER. It's not having them exposed to COVID or any other number of infectious agents that are around. Use parenteral opioids as appropriately, use them quickly, and assess them frequently. Make sure the patient's under control, but at the same time, make sure that they're being safe. They're not having acute respiratory compromises. Using incentive spirometry to help prevent acute chest if they've been admitted and you're taking care of them. It's a non-pharmacologic and it's pretty easy to do. I talked about a lot of different stuff, and I know that this can be very daunting because sickle cell patients can be very resource intensive, but at the same time, they are still they are a complex, acute, but generally chronic pain patient. So they have nociceptive pain, they have neuropathic pain. Use the same medications you know to use for nociceptive and neuropathic pain. Use them in similar doses. Look at your labs, frequently do reassessments, and talk to your patient. Figure out what they're able to do. What is it that they want to do? It just goes back to the basics of pain management. What do you want to do with your life that you cannot do because of your pain? I want to go pick up my grandkids. I want to go back to work. I want to do whatever I'm going to do. We're trying to get them back to a baseline that's normal so that they're not just living in the hospital. The number of kids that I saw back in Kansas City that were living on a PCA pump and that was considered mom or dad, that's a sad fact. I don't care who you are. If you're 5 years old and you're walking around with a PCA pump because that's the only thing that can control your pain, that's a real sad state. So that's really the bulk of what I wanted to talk about. I do have a case if you wanted to go through it, but at the same time, I also know that there are time constraints. So I will stop there unless Dr. McPherson wants me to keep going with like a quick case. I'm ambivalent, whatever is best for you all.
Well, let's see what questions there are. I started off with a question of what's a day hospital? Is it like an urgent center?
So what is a day hospital? So you've got an outpatient treatment facility, which is similar to an ambulatory infusion type of center. You would have the patient come in there to check in. They would be put into a chair, just like in an oncology ward. So you have
Oh,
patients that receive oncology care. This is the same kind of idea. But instead of them actually receiving oncology medications, they're coming in to get fluids, they're coming to get pain meds, and they stay there for a few hours. They've got a clinician that's working with them acutely, to like a nurse practitioner, maybe a full physician that's working there in the clinic anyway,
mhm.
so that the patient's going to be able to be acutely managed, gets IV access, gets parenteral opioids, gets fluids, and then that way they can go home.
I see. So it's sort of like a place you could go for your Spravato or something where you had to stay for a couple of hours.
Correct. Generally, they come in the morning and they'll stick around for between 4 to 5 hours. Some
Mhm.
people a little less, some people a little more. It depends on just how sick they are. Because some
Okay.
people will come in there into the day hospital and they'll determine, oh, your lactate dehydrogenase is high, your retic count's high. Maybe we need to send you to the hospital, but maybe your labs aren't that bad, and maybe we didn't draw them. We're just going to give you fluids because every time you've come in, you've just needed fluids and some pain meds and get you out the door.
Okay. Thank you. Let's stump Dr. Gregory. Who's got a question for him?
Uh-oh. Uh-oh.
Let's stump the chump here.
I do have a question, and I kind of remember talking about this at one of the other PGY2 topic discussions on sickle cell last year, but I know one of the things I had seen a couple of hospitals I was at were patients with sickle cell disease being maintained on buprenorphine for pain management or chronic pain management. And I remember trying to look into the literature. I really couldn't find like anything for it. So I guess I kind of want to know what your experience was with it or why it was so frequent specifically for sickle cell patients.
That is a great question. Since I haven't actually had any sickle patients probably in the past 5 years, and I know that buprenorphine has really gotten ramped up in terms of once CDC came out with their guidelines back in 2016, A, because it got them away from having to use Schedule II opioids, and B, the fact that you can use buprenorphine in order to kind of maintain somebody just based on the kinetics of the drug. It lasts for a long time. You can do sometimes once daily administration, kind of depending. I wonder if that's the rationale behind why a lot of clinicians went that route, which if it works, that's fine. But the problem that I generally have with buprenorphine is, keep in mind, from a purely mechanistic stance, this is a partial agonist. So if you have a patient that comes in an acute pain crisis, I now have to give opioids above what I would have to give for the fact that they're on buprenorphine, which also has squirrely kinetics. It also has a number of drug interactions. And on top of that, it binds to opioid receptors generally higher in a higher PKI than a lot of your others like morphine, oxycodone, hydromorphone. So you're going to have to overcome that in addition. So while I recognize that if you've got a stable patient and they've been on this and they have like no acute crises, and that's a patient that you can maintain on that drug for a long period of time, then sure, it makes sense to have someone on a drug that's appropriate for them. But if you've got a patient that goes in with a lot of VOCs and they've gone in for acute chest syndrome a couple of times, I'm going to be real cautious about having that person on buprenorphine, because think about when that patient goes into crisis, when they go to that day hospital. Oh, well, I can't just have it's 10 of morphine. And then we did 10 more. And then we did 10 more. And they're still not under control. Well, if I'm in a day hospital and I don't have access to a crash cart and all the other things I'm going to need in order to reverse the respiratory depression potentially, then they're going to have to go to the ER. So I can understand, just from a maintaining a patient that's stable on buprenorphine, I'm a little hesitant, especially if the person has a lot of VOCs. Does that make sense? That's a good question, by the way. I like using buprenorphine in a lot of patients, but you also have to be very aware of the fact that that's a double-edged sword. Just because it's once daily doesn't mean that it doesn't have risks. See methadone for that one. Again, I'll defer on that one because I don't like going up against blackjack versus thunder on that one, because I'll lose against Dr. McPherson.
But you wouldn't lose. But methadone, generally we don't dose once a day for pain. Do you use a lot of methadone for sicklers?
No, I can remember 2 or 3 people that I had that were on methadone,
Uh-huh.
but one of them passed because there were some other outside substances that were found in their system at the same time.
Oh.
So the other thing that I ran into was that this was in a teaching institution, and I've had learners that are maybe a little naive when it came to the kinetics of methadone, and they like to increase doses a little bit too frequently. And so I had a lot of folks that I had to get off that and get onto more of a stable morphine or an oxycodone, just because it did leave me a teaching opportunity, which was helpful. But at the acute patient care side, that I don't like having people in the unit for a couple extra days just because we were trying to essentially give them way too much drug because it kinetically caught up with them.
Who else has a question for Dr. Gregory? I have one more. I was shocked by your mortality data. That's just unbelievable. And you may have said this, so I apologize if you did, but what the heck's the cause of death?
So the cause of death in a lot of those instances, at least back in the 70s, was from acute chest syndrome that just never got diagnosed, and they died from acute pulmonary infection.
Oh God, that's awful. Do you think things have improved now?
Oh yeah, well, I mean, like with the numbers that I showed, once we got people vaccinated for pneumococcal infections,
Uh-huh.
that actually helped us out a tremendous amount. And I think that just from the fact that we're trying to prevent preventable diseases, especially when we have the means and we have the data that shows it, I think that right there in and of itself, that whole prevention instead of cure, that's a great place to be, because the patient has like minimal discomfort, if anything, from a one-time shot. But then if they're protected for 5 years or greater, that's wonderful. Because keep in mind that once those patients, especially when with those splenic patients, if you get all those sickle cells in that spleen and we have to do a splenectomy, or if the patient does an autosplenectomy on themselves because of all of those sickling cells, now they can't protect themselves against enteric organisms. So because of the loss of that enteric organism protection, because of the spleen, you got to make sure they get their vaccines. So that's probably another good thing for just overall pharmacist care. If you've got a sickler, you need to give them enteric pathogen vaccines when they discharge, especially if it's the first time and or if they had the splenectomy during that admission. It's just something really good to keep in the back of your mind from a prevention standpoint.
Mm-hmm.
So we keep seeing ketamine pop up in all the other pain-related disease states. Has it popped up in sickle cell?
I've used ketamine a couple of times. Most of that has been inside of the emergency department and into the acute care setting more than in the day hospital setting. However, I know that there are a number of other disease states where ketamine is being used frequently in the outpatient settings. And I know that in our outpatient pain clinic here in Springfield, they are looking at the use of short infusion ketamine for acute pain, for chronic pain management, which sickle cell pain could probably fall under. However, I don't have enough data to actually be able to say in this instance it's going to be the most appropriate thing. But at the same time, mechanistically, would giving ketamine to a patient that's in acute pain, is that really going to help there? Maybe not, but at least from a chronic pain perspective, that patient could be a good candidate just from a chronic pain type of perspective to receive regular infusions. But really from an acute situation, you can add that in there, but then now you already have your multimodal analgesia, or if you've made them NPO and they're going to be on opioids, you might be able to try to juggle that, but you're really going to want to be very cautious when it comes to making sure that you've got the appropriate set of vitals on there. They may need to go to the ICU for that, especially if they're getting it for acute pain management. So I'm a little hesitant to start there because you've already got one variable in the opioid, especially if you're using like a PCA for opioid pain management while they're in the hospital. I'm less likely to want to do both of those at the same time. But at least from a chronic pain perspective, if you were to try that, I don't think it would be inappropriate, but I can't give you, these are the data. Yes, it's safe. Yes, it would work.
All righty. Any one last question in the remaining minute or so?
I just had a quick question. This is more from the social standpoint, given that you're in the ED and I just don't have a lot of ED experience. I know a number of these patients will be labeled as drug seeking, but by the time I've seen them, they're on the floor, somewhat stabilized, whatnot. So is there anything that you are able to do, or not just you, of course, but like other providers in the emergency department that are able to sort of help prevent this labeling? Because like once it's in the chart, then that kind of follows them. So I didn't know if there was a perspective that you had just like being in the emergency department and sort of fielding these issues.
Sure, that's a great question. So actually, this just happened here not too long ago. The short answer is, if you really are that concerned about it, grab a lactate an LDH, grab a retic count, grab some objective data so that you can say to your providers or to whomever you're working with, this tells me that they might be in an acute crisis. If you don't believe them, if you think that they're just drug seeking. The other thing that I like to do just in general is, if I don't know you, or I'm going to give you the benefit of the doubt, even if I've seen the patient before, if I've seen you before, and as long as you haven't lied to my face, I'm willing to give you the benefit of the doubt, because if you're in pain, think about what your response is to pain. If you are in pain, you are trying to keep yourself in and you're going to lash out at stuff because you're acutely hurting. There are ways to kind of tease those out, and there are some things that some labeled patients will try to do, like, oh, well, I can only have this and I can only do this and this and this and this. You need to, as the clinician in the environment, as the expert, is say, these are the things that are safe. These are the things that I know work. We'll start low. We're going to go slow, and we're going to continue to do it in a stepwise fashion. If you approach everybody consistently, that's going to be less likely that they're going to get irritated and upset. And if they don't like the fact that you're not giving them the highest dose or what they say is the only way, but you're still following your own mantra, that's at least how I'm able to sleep at night. I had a patient that actually does have sickle cell, did come through here not too long ago. And I came in the morning, and the nurse from overnight said, there's this patient and I'm sure he's just faking it and this, that, and the other. And I sat there and I said, if you were having acute pain right now and you told me that, and I looked at you and you're just able to like tell me with a straight face that, whatever's going on, what if I labeled you that way? I don't like it when people label me for no reason. And sometimes you just have to get data on them before you can do anything else. So if we just try to approach everybody in the same stepwise fashion, that's the one thing that sometimes clinicians get tripped up over is, oh, well, I talked to this patient already and this is what my impression is. Okay, well, that's your subjective impression. You, as the clinician that's going to take care of the patient, need to lay eyes on them, need to talk to them, need to figure out what you want to do based on what you are looking at. So while they might be labeled that way, that's your opportunity as a pharmacist to say, here's what you're saying. I recognize and respect your opinion, but that's your opinion. Let me go form mine, and then we'll come up with the plan. So
I think on that's a wonderful note. And I think we should call it a wrap. So Dr. Gregory, thank you so much. Thank you
Thanks,
all
all.
for tuning in. And we'll see you next week.
Take care. Bye-bye.
Take care.
Thank you.
Bye-bye.